Hello, everyone, and welcome to Caring in Crisis, the Tuesday Briefs, a part of the Trauma Informed Faith Communities Project. I'm Reverend Mary Hughes with Crisis Care Ministries, and we're so glad that you've joined us today. A few reminders before I introduce our speaker today. We do want to let you know that this webinar is being recorded. At the end of the hour, we'll turn the recording off and we'll be able to be here for a few minutes for more casual conversation for just a little while. As you have seen in the introductory slide rotation, you can find all things webinar, details about our schedule, our presenters, and resources that they have provided at crisiscareministries.net. Just click on the webinar hub at the top of the page. I do want to say a special word of thanks to our funders and for those who are providing resources and training. It's been a wonderful collaboration of people who are really invested in this project, and we're so grateful for all of them. Throughout the webinar today, please feel free to type questions or comments in the chat box, and we hope to be able to address those questions and comments throughout and at the end of the webinar. You will receive a link to request attendance certificates, and I'm going to invite Kyla Powers to tell a little bit about that.
Hi, so to receive a certificate of completion for this session, essentially you'll need to fill out a request form. I'll go ahead and send the link to that form to you in an email along with the evaluation form link. You should receive it within the coming week or so. And when you get the email, just go ahead and fill out and submit that form. And if you have any questions about the process, just feel free to email me at kpowers@okumc.org, and I'll go ahead and put my information in the chat so you can see that.
Thank you so much, Kyla. And now it is my great honor to introduce to you Karen Orsi. For over 10 years, Karen has been the director of the statewide Oklahoma Mental Health and Aging Coalition, providing older adult behavioral health education and advocacy. She champions an approach to wellness as we age that includes both mental and physical health and promotes the integration of the aging, mental health, and disability and physical health networks. She has worked in and with both the aging and mental health networks and is a trainer and consultant with the Oklahoma Department of Mental Health and Substance Abuse Services. Karen is the vice chair of the National Coalition on Mental Health and Aging, chair of the Behavioral Health Forum on Aging, and serves on several advisory councils, governing boards, and planning committees. She developed the Older Adult Behavioral Health State Plan, the Reduction Depression Initiative, and the Oklahoma Department of Mental Health and Substance Abuse Services Older Adult Peer Support Specialty. She is a certified trainer for QPR, Talk Saves Lives, Healthy Ideas, Mental Health First Aid, and Mental Health First Aid for older adults. I know that you join me in welcoming our wonderful Karen Orsi.
Thank you very much for the kind words and your kind introduction. And I will begin the presentation as soon as I can get the slideshow going. There we go. Thank you for the introduction. I'm very glad to be here. Today is World Mental Health Day, but as Mary and I had a little conversation before this started, this probably should be called World Anxiety Day. It's very understandable that we're all struggling and that we're all in the midst of anxiety day in and day out, not just in our immediate state, but across the country and the world. So we're going to be talking today about older adult suicide. And I first want to say that many times talking about suicide is very triggering. Most likely we are all going to be impacted at some point in our life with suicide, either someone we know, somebody we care about, somebody we work with, maybe even ourselves. So talking about this issue can be triggering. So please be aware of that. And if you do feel triggered, please take care of yourself, step away, go outside, turn me off, or whatever you need to do. So with that said and done, here's my information. I also have a website if you want information about older behavioral health. And also the National Coalition has a website with much information. So I wanted to share that with you and to tell you also that we're not going to share the slides, but if there is a slide where you have some information that you want, please feel free to take a photo of it. So first of all, let's talk about who's an older adult. Well, it's a continuum. there is nothing written in stone. So we really don't know who an older adult is. SAMHSA, the federal organization, SAMHSA, Administration for Mental Health and Substance Abuse, they don't even have a standard definition of an older adult, but they often use anybody over 50. The Center for Disease Control says 56, you're an older adult, to over 100. The Department of Mental Health is now saying that at 50 plus, you're an older adult, and they're choosing 50 plus because they want as many people to aid as they age to have access to appropriate behavioral health. So basically, when we're talking older adults, we got, three groups here: those that are over 50. Then we have our boomers, 1946 to 64, that are 58 to 76 years of age. And then we have numerous advanced age people in their 80s, their 90s, and 100. So when we say older adult, we're talking about over a 50-year span of individuals who are very diverse. So we've got 5+ decades of diversity. So it's not just one lump group. And actually, it's not them. When I talk about older adults, I'm talking about us. Because that's the only thing we all have in common is that we're all aging. So first of all, I'm going to talk and give you some statistics from suicide in Oklahoma. And then we're going to talk about the 5 Ds of depression. And then we're going to go into what we know about suicide in older adults. So this is information from the Oklahoma State Department of Health, the Oklahoma Violent Death Reporting System. And this is the most recent information about older adult suicide in Oklahoma. Suicide data is always a couple years behind. So this is not dated. Like I said, this is the most current information. So from 2017 to 2021, as you can see, there were over 1,100 violent deaths, but 83% of those were suicides. And this is a graph that shows you the comparison between people over the age of 60 who died by suicide, and a comparison between Oklahoma and the United States. And as you can see, Oklahoma is overperforming across the board from 2001 all the way to 2021. Now here's age and sex specific rates of suicide. This is Oklahoma, 2015 through 2019. I call your attention to the right-hand side of the screen. The blue is male and the green is female. So look at the amount of suicides for 85 plus. It is the highest rate of suicide for the whole group. And even if you look towards the middle, that 75 to 84 still outperforms any other age group. So we have a very serious problem that we don't mean to normalize it because it's not normal, but it is a problem. And when we talk about suicides, usually the rate for male versus female, there's always at least 3.5 or more male suicides to one every single female suicide. However, females have more attempts than males. At the same time, for females, it seems, as you can see from this graph pretty much shows, is that for females, the suicide rate tends to increase until about middle age or so and then begins to decrease, whereas for men, it almost continuously goes up. So this is a graph that's a little bit dated. It's the previous information from the State Department of Health, but I thought it was easier to see because it was more visual. And this screen shows circumstances by life stage. So as you can see, the top is 65 plus, the bottom is for young people, 10 through 24. But it shows you some of the differences in age, circumstances, and ages that have been identified. And for Oklahoma, the top 3: physical health, the green; mental health problem, the red; and current depressed mood, the blue. So as you can see, different age groups have different circumstances. And for instance, for 65 and plus, one of the circumstances is probably not going to be an intimate partner problem. And yet for younger people, it could be an intimate partner problem. On the reverse of that, for younger people, you're not going to see a lot of physical health problems, whereas we see that as a primary for older adults. Now here's the current information. As you can see, it's not as colorful, but it still stands true that the top 3 for both males and females are physical health, depressed mood, and mental health condition. So we have to address mental health disorders and suicide. So there's no single cause for a suicide. There are multiple intersecting factors. So what that means is that you've probably heard many times, you hear about a young person that's been bullied at school, and that young person dies by suicide. So everyone assumes that they died because they were bullied. Well, that's not true. That bully situation did contribute, but there were going to be other circumstances. So it's not just one circumstance that causes a person to make a plan and to kill themselves. So we talk about mental health disorders and suicide. The large majority of suicides have a mental health disorder as a contributing factor. However, 1 in 4 of us will experience a mental health disorder in our lifetime. And most of us are not going to go on to kill ourselves. So again, mental health is a circumstance, but is not the only circumstance. And that when people are thinking about killing themselves, it's because they've reached a crisis point. They are desperate to end the pain, whether that's physical, emotional, or both. But they also have tunnel vision. They have limited thinking. They can't see the forest for the trees. They can't find solutions to the problems. They can't find anything to do except end the pain. So again, that crisis point has been reached. And I want to preface to this information, we're not talking here about individuals that have terminal illnesses and that in severe amounts of pain every minute of every day here. We're talking about people who we don't know. Can they be helped? Can they get help? If they are in pain, are there treatments that can help alleviate some of that pain? So again, this is not a presentation about people with terminal illnesses and severe pain. So again, the top circumstances for older Oklahomans: physical health problem, mental health problem, and current depressed mood. So now, while older adults have lower rates of mental health and substance use issues than younger people, those issues have more profound effect because of older adults have older bodies. They've got aging bodies and aging brains. So these issues can have a much more profound and disastrous and dangerous impact on them. And in fact, most older people, even into their 90s and beyond, are more satisfied in their lives than younger people. And that even showed during COVID with all the upheaval. Many of the older adults self-reported that they were coping better than younger people because of the fact that older adults are resilient. Older adults have been through a number of wars and upheavals and all kinds of situations over their lifespan, and they have good coping skills. So this is a presentation about 5 Ds of older adult suicide, and this is based on the research and the training that is done by Yates Conwell. He is one of the primary researchers on older adult suicide prevention, and he examines the issues and helps us find ways to prevent older adult suicide. And he has developed what he calls the 5 Ds of older adult suicide, being depression, disease, disability, disconnectedness, and deadly means. So we are going to go through each one of these now and show the connections between each of these things and suicide. So first of all, let's talk about depression. Depression is a common mental health condition for everybody. It is also a very common mental health condition for older adults, but common does not mean normal. It's a mood disorder. It causes feelings of sadness, loss of interest in things you used to enjoy, loss of interest in activities. Many people just say they feel empty or don't know what they're feeling or don't feel anything or feel numb. It can cause all kinds of difficulties with thinking and remembering and eating and sleeping. It is very treatable, but it's a physical disease that requires treatment. It is treatable. And older adults, contrary to what society may tell you, recover from depression on a basis equal to or even greater than younger people. And if it is untreated, what can happen? Well, it can worsen. It can last longer. It was also shown that people with untreated depression, it worsens their physical symptoms. So their diabetes is worse, their heart disease is worse, their pain is worse. It can, in severe cases of depression, it can lead to self-harm and suicide. And again, it is not a normal part of aging. It is not a symptom of cognitive decline or dementia. It is defined as a low mood, a reduction in energy, a loss of pleasure in activities, a decreased activity lasting more than 2 weeks. And again, it's not just having a bad day or a bad couple days or being down for a day or two. This is something that's lasting for more than 2 weeks at a time. And what causes depression? Well, there's a whole number of things, as you can see here. One of the important things to know is that chronic diseases and the medications to treat them can increase your risk for developing depression. Also, your brain chemistry, genes, family history, being lonely, having stressful life events, experiencing losses. And those losses aren't just the loss of people. It can be the loss of autonomy, the loss of hearing, developing incontinence, vision problems, having to feel dependent then because you feel like you're losing your autonomy, declining memory, lack of exercise, sleep issues, and trauma. So now the behavioral health and physical health, there's a very strong relationship. In older adults, physical, behavioral, and cognitive conditions, the symptoms of those different conditions overlap. So it can be very difficult for diagnoses. However, we know that depression often occurs with physical health conditions, but older adults sometimes exhibit their depressive symptoms not in the usual sadness and crying that you might expect, but in aches and pains, feelings of emptiness, or they lose interest in activities. And with men, many times you expect that someone who's depressed would just withdraw. Well, sometimes for men as they age, they exhibit their depression in aggression and irritability. So as you can see, the symptoms present differently for older adults than they do for younger people. So physical health conditions would often present as behavioral health concern or cognitive impairment. Behavioral health conditions often present as physical conditions or cognitive impairments. Again, older adults are complex. And what are the risks for developing any kind of behavioral disorder, much less depression? Well, older bodies means enhanced risk. And what are those risks? Chronic diseases. People are also traumatized when they get a diagnosis. Disability. And disability we'll talk about a little bit later. We're talking functioning. Changing of role and life transition. And we have to wonder once, for instance, people retire and their roles change, they're no longer maybe managing the hotel, but they're no longer CEOs of the company. When you lose your role, do you lose your social value? Well, many times it seems to that is exactly the case. Being isolated and lonely, trauma from life events, self-medication, and we all self-medicate, but some people don't have options and don't make good choices. So for instance, you may self-medicate by playing with a puppy or eating a Snickers candy bar, whereas someone else, their only options for self-medication is a bottle of vodka or a vial of medication. And then there's actual medication misuse and abuse, and then grief and loss that I already mentioned. Now we're going to talk about disease. So aging and disease, what's the landscape? Well, older adults are disproportionately affected by chronic conditions, and we've got some listed here. 85% have at least one chronic condition, 60% have two or more. And we know that chronic diseases and the medications to treat them increase your risk for developing behavioral health disorders. So as you can see, older adults already have an increased risk. Now, suicide disease. We know that certain diseases are strongly associated with the increased risk for suicide. Things like dementia, epilepsy, or neurological conditions, central nervous systems. We know also there's an association between something like hearing loss and suicidal ideation for both for middle-aged and older adults. So usually we don't think of, we think of everybody's got a little hearing loss as they age, but that also increases the risk for suicide. And here's an example just for veterans. Attempts were 73% higher when they just got a diagnosis of mild cognitive impairment. I mean, mild cognitive impairment should not cause a suicide, but yet it does, or at least an attempt. And 44% higher than people that had a diagnosis of dementia. So it just shows how vulnerable people can be and how we really need to pay attention when people get diagnoses, and we support them into doing screenings and follow-up screenings. Parkinson's disease is also associated with increased risk of suicide. And then also 65 and older with Alzheimer, with other dementias, are 2 times as likely to die from suicide. And the highest rate is for that, a group 65 to 74 within like 3 months or 90 days following that diagnosis. Again, how important it is for the screening to be done at the time of diagnosis and follow-up. And here's a slide from the University of Rochester just talking about suicide and comorbidities. So on the left-hand side, you have your estimated risk of suicide, and on the bottom, you have your number of illnesses. And the slide shows very clearly that suicide rates increase with every diagnosis, every chronic disease. And now we'll talk about disability. And again, disability means functioning. Being able to maintain independent function and autonomy, it's critical. Everybody wants to be independent, but to be independent, of course, we need some resources. And people, as we age, we're going to need to redefine what we regard as acceptable independence. And it's a transition that we're all going to need to go through as functioning is impaired, as functioning changes, because we have aging body and aging brain. And some people become increasingly suicidal or at a greater risk when they're trying to manage their functional impairments. An example of that would be like the association I mentioned in the earlier slide between hearing loss and suicidal ideation. And here's just some cultural considerations, just something to think about. You saw that chart where we had the highest rate for 85 and over. Well, that 85 and older is white men, 85 and older. Not all ethnicities. White men over 85 have the highest rate. And here we're saying ages 65 plus white men account for 80% of all the suicides. Now, why is that? Why is that? Well, we don't really know for sure, but some of the considerations, what makes older white men so vulnerable? Well, we have to look around, and we know when a young person dies by suicide, the community is outraged. And there are trainings. On television, you'll have the Suicide Prevention Lifeline number on the bottom of the screen. The schools will call parent meetings. A number of things happen, and rightfully so. And it is a tragedy. We should be outraged. When an older adult dies by suicide, there's kind of this collective shrug. This, well, she was sick. Or, oh, he was in pain. Or, oh, they're better off now. When in fact, it should be just as outraged as the 13-year-old. Do we say that when a 13-year-old dies by suicide? They had nothing left to live for. They're in a better place. They're out of pain. So there seems to be this kind of social acceptance and a permissive attitude. People who are older that choose to die by suicide, or people who are ill or have disabilities that we understand when they die by suicide. So that belief that aging is an undignified situation, it could be a very masculine response to aging than to kill yourself. Who wants to deal with all the inequities of aging? Who wants to deal with all the mess of aging? So if suicide is viewed as a deliberate, powerful, strong act by a man, it's just an association that makes it acceptable. So maybe that's something that we need to consider, that we are a society that has kind of a twisted definition of masculinity, and that twisted definition, I think this cultural considerations kind of reflects. Now let's talk about disconnectedness. This is a very important piece. It's a prevention strategy. So now as we age, it's very natural that our social connections, our social networks are going to shrink because we retire, and maybe because of some functional situations, maybe mobility situations, maybe hearing or incontinence or vision. Maybe we don't get out like we used to do, or we don't connect like we used to do. So little by little, our social networks shrink, and then our isolation risk increases. And we know that loneliness and isolation can impact both your mental and your physical health. There's something that we call thwarted belongingness, and that happens many times as we age because we no longer feel like we belong. We can't find a meaning in life. We no longer have those social roles that used to define us. We don't feel like we're making any contributions. And also society tells us, you're not making any contributions. When in fact, we know that's really not true for the older adult population. And older adults, many times, as we age, become invisible, become marginalized, are not invited to participate, are not wanted to participate, and mostly just told that they're a burden. They're a burden on society, and they're in the way. And this is, again, from the University of Rochester, but it shows you how important social connection is to our mental health, cognition issues, functional status, and physical health. So social connection for cognition, people that are connected and stay somewhat active have better memory, they can plan better, and their risk for dementia lowers. Functionally, their mobility can improve, their self-care has shown improvement, and they get stronger. Their physical health, their subjective perceptions. It's very important that, for an older adult that has chronic conditions, and most older adults develop at least one or more chronic conditions, your perceived health, having that optimistic view that you can manage it, is a huge difference to somebody that just crumbles. They crumbles with the diagnosis, they crumble with the symptoms, they crumble with the medication. So that subjective perception of your physical health is extremely important. I remember that as one of the three circumstances, top circumstances in Oklahoma: physical health. So whether that is just actually the number of chronic diseases, or is that the chronic diseases and your perception of your health? And then there's mental health. Your social connection can decrease your risk for developing things like depression and hopelessness. It increases your well-being. And we know depression and hopelessness factor in to people that die by suicide. And this is a chart from this is a interpersonal theory of suicide. As you can see, on the left-hand side, we have that thwarted belongingness in the red. And next, on the right-hand side, that perceived burden. Remember, I mentioned that older adults don't fit in, and I'd asked to participate, feel like they don't belong, they're invisible, and that they're a burden. And then right in the middle, when those two combine, and then the person has the capability, meaning access to means and making a plan to kill themselves, then we have a perfect scenario for suicide. And this, I want to show you this slide. I mentioned before how complex older adults can be. Well, we know that in suicide, with COVID, the decision was made that because we knew that older adults were most severely affected by the COVID virus, because the fact that they had older bodies, they had medical illnesses. So in order to keep them safe, we had to social distance them. Well, when we social distanced older adults, what happened is it led to disconnectedness, which led to loneliness, and disconnection and loneliness altered their immune function and increased their risk for developing COVID-19. So as you see, things are complex with older adults, and things can be difficult with older adults. I shouldn't keep saying older adults, things can be difficult as we age. And here's a chart showing the general population on the left compared to older adults. You can see for the general population, for one death by suicide, there have been 5 hospitalizations and 30 ER visits. On the right, for older adults, there's 1 death for every 2 hospitalizations and 4 emergency department visits. So as you can see, there are not many opportunities to intervene for an older adult. And we'll talk about that in just a couple more minutes, but we already talked about the decreased social circles. So we don't have many opportunities. We need to recognize signs and symptoms. For the most part, a general statement is for older adults, the first attempt is usually fatal. Whereas for other age groups, there may be many, many attempts before there's a fatality. And now we're going to focus on deadly means, the access to deadly means such as firearms and medications, which are the most popular. 75% of older adults used a firearm compared to 50% of the general population. And we know that they are very accessible here in Oklahoma and many other states. So the method of suicide among older adults in Oklahoma from 2017 to 2021, as you can see, for the most part, firearm 81%. And of course, followed by things like hanging and strangulation, sharp blunt instrument, falls, others. And then on the right-hand side, you can see that, for the most part, a handgun was used, followed by the shotguns and the rifles. So that is a big red flag for all of us. If we know someone is struggling and they do have a firearm in the house, we need to be very much aware that increases their risk. Having that access to means increases their risk tremendously. So when we're talking about preventing a suicide, time is critical. We want to put time between a person and means. So for instance, if you do know someone who's struggling and they do have the firearm, secure the firearm, remove the firearm, take the ammunition out, store them someplace else. Put the gun in a cabinet, lock it away somewhere, and put the ammunition in the shed or whatever. Or if it's a situation of medications, if someone has a lot of opioids, lock the opioids up. There are lock boxes that are available. And research findings have shown, research on access to means has shown that if we remove the chosen means, the person just doesn't go and get another mean. They just don't find another method, which gives us time to seek help. Now, one of the myths of suicide is that we can't stop suicide. If somebody's going to do it, somebody's going to do it. There's nothing we can do about it. If you take their gun, they're going to go get a knife. If you take their knife, they're going to go get a rope. Those are myths. That is not true. So it's very important to know that if we remove the chosen means, then we have time to help somebody get some help. So now let's just talk. We talked about the 5 different elements that Dr. Yates Conwell stresses. And as you can see, they really are all interconnected. But now we're going to talk about, we're going to go do an overview. And I'm trying to get rid of something that's blocking my view. I'm not doing a very good job. There we go. In 2022, the 65 plus accounted for 18% of all suicides, but just 12% of the population. So as you can see, older adults are overrepresented in the number of suicides compared to their population. And we know that aging bodies have chronic diseases. Aging people have life transitions. Aging bodies with diseases have medications. And all those things increase a person's risk for developing a mental health disorder. 1 in 4 older persons who attempt to kill themselves will die, compared to 1 in 200 youths. That's a drastic difference. Older adults, especially men, have much higher death rate than other age groups, and that's from SAMHSA. That's the Federal Mental Health and Substance Abuse Services Organization. Now, to continue talking about the overview, I mentioned about breaking it up, this diverse group of people, ages maybe 50 to over 100. They have a lot of differences between them. Now, that first group, the plus 50 and the boomers, are probably going to share a lot of culture, but they're still going to be very different, because someone who maybe is 50, from 50 to 60, they're probably still working. They maybe have different kinds of insurance. They're still going to have their social circles. They're not going to be as isolated. They still be lonely, but I mean, they still have their social circles. So they're going to be a little bit different. And then we have our boomers, who have their own cultural experiences of sex, drugs, and rock and roll. And they do pay the price for that. You know, for instance, sex, there's a high HIV rate. Rock and roll, there's a lot of hearing loss. So those are issues. And then with drugs, older adults that boomer age group, they're much more familiar and much more comfortable with things like drugs and substances, because that's part of their culture. But let's focus a little bit on that very high rate. We're talking about the 85 plus and the 65 plus, but primarily the 85 plus that has the very highest rate, the 85-year-old white guys. But when we talk about advanced age people, 80, 90, and 100, it's a growing population. That is one of the largest populations that, because of our medical advances, they have a culture of bootstrap strength and self-reliance. And you all know what I'm talking about. Older adults of advanced age are stoic. They do not use mental health services. And one of the most prominent ways that we can prevent suicides is clinical services. But yet this age group does not use mental health services. Their culture and their experiences, they don't include any kind of positive views about treatment and recovery. They don't know anything about treatment and recovery. They don't believe anything about treatment and recovery. However, they trust and utilize primary care. So that is really a big opportunity to integrate care. If we could integrate our mental and physical health, like I gave you examples before of how the chronic diseases are associated with increased risk for depression and increased risk for suicide. Well, we need to have those screenings done in primary care, so that people are recognized as having, that they are in distress, that they need help, and they need help now. So while it is an issue, but it's also an issue because primary care, I'm not trying to disrespect our medical profession, but primary care doctors are neither trained to diagnose nor treat mental health conditions. And yet the vast majority of mental health conditions of advanced age people are treated by primary care physicians. So remember a few slides back, I mentioned exhibiting aches and pains as a sign of depression. Well, what happens if you have aches and pains and you go to your primary care? The underlying symptom is not looked for. Most likely what happens with aches and pains is that you get another medication. And if you're already taking several, that can increase your risk for an adverse effect, which can lead to something like a fall or an ER visit or hospitalization even. And of course, it's going to increase your healthcare costs also. So that is a problem for this advanced age group because they don't use mental health services. And many times people don't have access to care, especially in the rural situation. Even here in the urban area, we're not doing that well in terms of having enough providers to provide professional treatment. And then we know that the symptoms of mental health conditions and physical health conditions and cognitive conditions overlap. So it does make it difficult. Again, we're not in the business of diagnosing, but what we can be in the business is recognizing signs and symptoms, recognizing when someone's in distress, and then helping them get the help they need. Mental health conditions present differently than younger people. We've already mentioned that. So many times the symptom that presents for things like depression is not what we expect to see. So a lot of times just kind of don't pay attention to it. And because of ageism, many times symptoms are misidentified or ignored. So what do we know about suicide? Well, we know some, but obviously we don't know enough. What we know is that 77% of older adults who died by suicide saw their primary care provider within the year that they killed themselves. 58% saw their primary care provider within the last month of life. Now, again, I'm not disrespecting our medical profession, but I'm just showing you how important it is that we integrate care for older adults, those that are using primary care. And when they went to the primary care, the questions were not asked, and the older adult did not volunteer the information. They didn't go to the primary care saying, I feel depressed, or I feel empty, or emotionally I'm distraught, or I don't have any, I feel empty and don't have any interest in my activities. They didn't provide any of that information, and none of the questions were asked. And as such, you can see the result. We know that as we age, older adults have higher rates of completions, 1 per 4 attempts for older adults, 1 completion per 100 to 200 for younger ages. From 2011 to 2015, the rate of suicide for white men 85 and over was 4 times the general population. Older adults have access to lethal means like firearms and medications. There, a lot of people are taking the medications to include opioids, and everybody and their brother has an arsenal on the coffee table, it seems. Older adults have more fragile bodies, and I don't mean to say that in an ageist sense. I just mean as the body ages, the body changes. Your blood flow changes, your joints change. You can look in the mirror and see the wrinkles and the gray hair, but you can't look inside and see how the liver has changed, or the kidneys have changed, or how the heart is weakened. And those are all things that naturally happen as the body ages. Older adults also have poorly controlled pain many times. So the joints and mobility problems. They also have that advanced age group that I mentioned earlier that don't do mental health. They were also brought up in a culture of secrets and shame. You don't talk about what happened to you. If you do, it's shame. You bring shame on the family. You bring shame on yourself. You remain stoic. You deal with it. You somehow deal with whatever cards you were dealt. And that's their culture. And so that is what they're doing. Their bootstrap mentality. And it can be, bootstrap mentality can be a real strength. It can also be a real weakness. So we need to make sure that our older adults are supported and know that asking for help is not a sign of weakness, and that their independence is threatened. It's a sign of strength. We know that older adult group, the advanced age group, don't use mental health services, and their attitudes about treatment and recovery are non-existent. And finally, those symptoms are often misidentified or they are ignored. Many times people think that that's what's supposed to happen, right? They're old. That's what happens when you get old. You're in pain. You should be sad. You should be hurting. You should be lonely. That's what happens, right? So many times symptoms are just assumed to be a part of aging. We know that suicidal behavior is more lethal in later life than any other point in the life course. Older adults are more frail, so they're more likely to die. An 85-year-old body is not going to recover like a 42-year-old body might. They're more isolated, so they're less likely to be rescued. If nobody ever checks in on Mr. Jones down the street, Mr. Jones could be lying on the floor, but nobody knows that. They're more planned and determined. Older adults do not mess around when it comes to suicide. They don't make iffy choices. They're lethal. So this is just to give you some information about looking for some signs and symptoms. What a person may say who's thinking about suicide. They may talk about being a burden. That's a big one. That's not a red flag. That's a red banner. Just like, you know, just talk about the 5 Ds. That's a red banner. Or people talking about not having a reason to live, or people thinking about ending their life. Now we got to stop there for a moment, because as people age, especially the advanced age, it's normal to have thoughts about death and dying. But what's not normal is about talking about making a plan or talking about killing yourself. There's a difference there. So when people are saying about being a burden or not having a reason to live, or talking about ending their life, that's not attention-seeking behavior. That's attention-needing behavior. We need to take it seriously. We need to follow up. We need to engage. What do you mean? Tell me more. What else can you tell me about what you're feeling? What a person may do. Well, you may see some behavior changes. They may start isolating themselves, doing some, maybe acting recklessly, increasing their use of alcohol or drugs, or they may start displaying some moods that aren't the usual situation that you see. They may, have that loss of interest. They may start going into rages or be irritable, or acting like they're just totally invisible and humiliated, and may have anxiety. And then there's listening for suicidal thought. This is from the Manhattan Coalition on Mental Health Issues of the Elderly. If you hear someone saying life isn't worth living, follow up on that. I feel my family is better off without me. That's pretty similar to saying I'm a burden. Suicide is my only way out. Or take my possession, I won't need it anymore. Ending the pain is all I care about. Or next time I'll take enough pills to do it right. And now we need to talk about ageism. Ageism is one of the big isms. It's just as ugly, it's just as dangerous as racism. It's just as ugly, it's just as dangerous as sexism. However, not all of us are going to experience racism. Not all of us are going to experience sexism, but we are all going to experience ageism. In fact, many of us probably have already experienced ageism and will continue. So what is ageism? It's defined as a form of discrimination and prejudice. It's directed at older adults. It's experienced by older adults, where societal norms marginalize older adults, treat them with disrespect, make them feel unwelcome, incompetent, and invisible. So it is not just people being too sensitive or people that can't take a joke. It's not just a bunch of snowflakes having their feelings hurt. That's not at all what ageism is. Ageism is dangerous. Now, why am I saying ageism is dangerous? Because it interferes so much with a number of things. It can interfere with identification and screening. It can interfere with treatment. So for instance, if you believe that, now go ahead and fill in the blank. I'm going to use depression because I'm talking mental health and suicide. If you believe that depression is normal for an older adult because they've got all these life changes, they've got losses, and they're great, they should be depressed. Or I believe that, of course, they should not be sleeping well, or they shouldn't be eating well because they've got all this stuff going on. So if you believe that depression is normal for an older adult, you're not going to screen for it. If you believe that arthritis is normal for an older adult, you're not going to screen for it, which means a person's not going to get any kind of treatment, maybe any kind of pain and information or medication, or may not get any kind of physical therapy referrals. So you can see how important it is that we address these false beliefs. It is not normal for an older adult. On the flip side of that, if you're one of those people that feels that you couldn't ask an older adult an intrusive question because it is so sensitive and it is private and it is rude. I couldn't ask grandpa how much he's drinking, or I couldn't ask mom if she's smoking pot. Well, if you care about mom and dad or grandpa and grandma, and if they're taking a lot of medications and have chronic diseases and maybe seem like they have some emotional issues right now, you probably should ask them. If they're not too sensitive, you care about them, it's not rude to ask a critical question. So you can see ageism and our beliefs about aging can really interfere. In terms of professionals, it's not just maybe community that might be ageist, but our professionals are raised in those communities. We're all surrounded by ageism. We grew up with ageism. We're told from day one, the last thing in the world you want to do is grow old. It's awful, it's horrible. That's the ageism we were all raised with. So our providers are raised with the same thing. So in terms of providers, are they wondering, can an older adult really get better? Are they really worth the time and effort? They're probably just going to continue to spiral downward. They're probably untreatable. They're probably going to just deteriorate. So as you can see how the ageism, how our perceptions, our false perceptions of ageism can interfere. That happens many times with suicide. People think it's normal that an older adult would want to die by suicide. Or people think that it's normal that an older adult would express the signs or symptoms that they're showing for suicidal ideation. And then we have on the bottom left there, there's over and under treatment, where because of ageism, we dismiss a treatable pathology as just a feature of old age. And that's the example of if we dismiss the pain of someone with arthritis as just that's part of aging, then someone's not going to get treatment. If we assume that depression is just a normal part of aging, or thinking about suicide is just a normal part of aging, we're not going to help a person get help. We're not going to help them get treatment. On the flip side of that, ageism interferes because it can treat expected changes of aging as though they were diseases. So for examples for that is that grandpa can't remember the first name of his doctor, so we've got Alzheimer's Association on the speed dial. Or mom put her keys somewhere and can't find them. Uh-oh, we better get that room reserved at the assisted living. It's cognitive impairment, here we come, dementia, here we come. So again, overreacting to things that are regular, normal, usual, expected aging brain and aging body. And then we have this conundrum. Are we going to look at older adults and look at them as being fragile and vulnerable? Or are we going to look at older adults and see them as being strong and resilient? So that's how ageism interferes. There are some screening tools available, but before I do that, I just want to go back and just say one more thing about the ageism. Ageism is like stigma. You hear a lot about stigma and mental health that really prevents people from getting help. Ageism can do the same thing because people can self-ageist. They can internalize the ageism that surrounds us. And it's very difficult not to, because, as I said earlier, we're taught from day one, the last thing in the world you want to do is age. And yet we're powerless to stop it. There's all kinds of things you can buy. They're supposed to help you, but that's not really true. They don't really work. But people who I self-identify with that ageism, what happens with them is that they take on the false perception. So for instance, an older adult then may not tell their family or their doctor that they're in pain. They may not tell their family or their doctor that they're feeling sad or lonely, or that they're feeling empty. They may not tell anybody that they're feeling suicidal because society tells them they're supposed to feel that way. So they don't do anything about it. So again, ageism is so dangerous, the ageism that surrounds us. And then when people absorb and they become self-ageist and they believe all the negativity that surrounds them. So I wanted to leave you with a few things here. The screening tools, there are some screening tools available that are not just for professionals. There's screening tools that anybody can use to help identify someone in distress. There are many different screening tools here. I'm focusing on depression and I'm focusing on suicide. There's a 2-question depression screen. There's a geriatric depression screening tool that's 15 questions. And there's a 2-question suicide screen. So the 2-question depression screen, during the last 2 weeks, have you often been bothered by having little interest or pleasure in doing things, yes or no? During the last 2 weeks, have you been bothered by feeling down, sad, or hopeless, yes or no? The answers that indicate depressive symptoms are in bold. Now, this is not a diagnosis. This is a screen that just gives you some information as to whether or not someone has depressive symptoms. And then from there, we can find out how strong those depressive symptoms are, which will indicate what kind of treatment a person might need, what kind of referral the person might need. So that's the 2-question depression screen. Then there's the geriatric depression scale. And this is recommended for consideration of use, and we are recommending it here in Oklahoma for our community mental health centers. They're called CCBHCs now. Certified Community Behavioral Health Clinics that offer integrative care. And this is a self-administered scale with yes or no responses. It's designed for use with older adults. There's other screening tools out there that are for all populations. This one is designed specifically for older adults. And it's got a look back period of over the past week. which is very user-friendly because some of the tools go over the past 2 weeks, over the past month, over the past 3 months. And for someone even with a mild cognitive impairment, that can be a little difficult and that can be confusing. It only takes about 5 or 7 minutes to complete, and it is validated in the ability to differentiate between depressed and non-depressed individuals. Now, the target population would be for older people, people who are aging, healthy, they're healthy but medically ill, mild to moderate cognitive impairment. And we're hoping it's going to be used extensively in community, acute, and long-term settings. It has strengths and it has limitations. It's not a substitute for a diagnostic interview by mental health professionals. So again, this is not a diagnostic tool. This is a tool that can be used, first of all, to identify people that have depressive symptoms and to weigh how severe those symptoms may be. So if those symptoms may be normal, there may be very easy ways to deal with it and decrease those symptoms. If those symptoms are pretty heavy, they probably need to see a mental health professional. If they're very heavy, this person may be at risk for suicide. So again, it's a very helpful tool. Then there's a 2-question suicide screen. Now, usually what we're recommending, what we're training is that if a person has a score of 5 or higher in the geriatric depression screening tool, then we would follow with a suicide screen. But it can also be used if you're really concerned about someone who's expressing those situations or those comments that we said a little bit earlier. So the 2-question suicide screen is, over the last 2 weeks, have you had thoughts that you would be better off dead, or that you wanted to hurt yourself in some way? Yes or no? Well, if the answer is yes, then we say, do you feel these thoughts are a problem for you or something you might act on? If the problem is yes, okay, well, those are two big yeses that show this person needs some immediate help. So basically what we need to do is we would caution them to get some help immediately. And we would follow, if you're working at a situation or you're in a place that has a suicide protocol, you would follow it. And that includes calling 988, which is the crisis line that we'll talk about in just a little bit. Now, if you're in a situation with someone and you know that they have plans to kill themselves and they have the means available right then and there, do not put yourself at risk. We'll call 911 first in a situation like that before we call 988. Never to put yourself at risk when someone has a plan and has the means available at that moment. So now finally, we're going to talk about the crisis line. Now, if you don't have this number, I know it's a number you think you'd never forget, but at the same time, when you're in crisis, you have to stop and think, are we talking 988 here? Are we talking 911 here? Are we talking 211 here? What's the number? Please put this in your phone. Please share this information with anybody and everybody. 988, the mental health lifeline. Now it replaces the long number that used to be the suicide prevention lifeline, but this is not just a suicide lifeline. This is an everything mental health lifeline. So again, please put it in your phone and please share it because there is hope. This is a dial 988. You can press 1 for veterans, press 2 for Spanish. You can text. Now, currently in Oklahoma, we just have English only for texting. There is a crisis text line here to give you the information, but you can also do it in Spanish with using those numbers that are on the screen. You can text to the trained crisis counselor and the crisis text line phone for free, 24 hours a day, 7 days a week. And this is for anyone experiencing, witnessing mental health crisis. So it doesn't matter if it's somebody you know, somebody you care about, you yourself, someone in your household, someone in your class, someone at your church, anyone that needs help. If you don't know what to do or how to help them, call 988. Okay. Now, if you want to connect them to resources, call 988. Anyone needing support for depression, anxiety, sadness, loneliness, and grief, any of those situations. So it's very important that we let our older adult population know that this is for them. It's not just for young ones. This will be resources for everybody, and the responders there will link a person to right services. So even if someone calls and says, I need help with food, 988 is not going to hang up on you. 988 will connect you with resources for food. If you need something like, I'm not saying to use 988 for something silly like calling a cab. But for instance, if someone that needs transportation to get to the hospital, that gets pretty serious. I mean, those are the kind of situations you can do 988, and they will link you to the right services. Now, calling 988 when it's a more serious situation. The situation that we have here in Oklahoma, the plan that is developed is a comprehensive plan. So if a person calls 988 and they need more help than can be given over the phone, for the most part, 98 with resources shared over the phone, many things can be taken care of, and people with a lot of distress and pain can be alleviated over the phone, giving those resources. But if that cannot be done, the 988 can send a crisis team of people to that person. And if there needs to be more done after that, the crisis team can transport the person or provide transportation to a crisis center. And from there, they can help a person get an appointment with a mental health professional. And then they will also follow up to make sure that that the person kept the appointment, that they are going to be in treatment. So as you can see, the system is pretty elaborate. And it's a little over a year old, and it's already answered thousands of calls. And as we know, we are all in an environment right now of anxiety. It is very normal for everyone to be feeling stressed and feeling anxious. However, some of us have stronger coping skills than others. We know that older adults are resilient. At the same time, when life is slapping you around, when all these things are all happening at the same time, sometimes our coping buckets get holes in them and our coping skills deplete some. Sometimes we need to find new coping skills, or somebody needs to remind us about how strong we are. So again, it's very common for all of us to be stressed out right now. So we need to ask for help, how important it is. And in terms of recovery, people can and do recover even from very serious illnesses every day. And the important thing is to get treatment. So here's the last bit I'll leave you with. These are some resources for suicide prevention that I'm leaving you with. You can see I've got some trainings that are available: Talk Saves Lives, QPR, Assist. There is going to be very shortly, it will be posted on the Department of Mental Health's website, but there is going to be a 98 fact sheet on statistics for suicide in older adults. And also we'll be developing a toolkit for identifying and trying to prevent older adult suicides. And then the Training Institute, there are many trainings that are available there that are free about aging. There is also a couple of toolkits from SAMHSA that are available, giving the information there. There's the Suicide Prevention Resource Center, the Foundation for Suicide Prevention, and then of course SAMHSA has some resources for older adults on their website. So those are all things that are available to you, and I hope that you take advantage of some of them. So with that,
Karen, we do have a number of questions. Can you see the chat, or shall I read them to you?
I can do both.
Okay, some great questions, and your presentation is just so pertinent to our folks. I'm guessing everyone here on this Zoom, as you had said, has experience, and many of our folks here have unfortunately had to care for families in their pastoral role who have experienced this. So first question, is being single also a factor, losing spouse?
Yes, it is, absolutely.
Okay.
It's also shown that things like losing a spouse and being single also can contribute to the use of, for instance, like alcohol. That's one of the highest rates. Some widowers over 75 have the highest rate of alcoholism in the country. So yeah, being single can be a factor increasing your risk.
Wow. Okay. James asks, if you are an older white male, the list of isms given usually points to you as the cause of all ills. Is it any wonder that older white males remove themselves from society? That has to do with the belongingness.
That's that's a very painful question. That is very true, and as it stands right now, we have many misperceptions for a lot of people. Ageism is, like, as you state there, it is one of the big isms, and it can point to you as the cause of all ills. I think that what I would like to see is, rather than removing yourself from society, is standing up and challenging the ageism. I mean, we've got to think back to the hippies. Peace and love, flowers in your hairs, tambourine, free love. But where did that end up? They removed themselves from society, right? They removed themselves from the political arena. I don't know what happened to all the hippies. I assume most of them were investment bankers, because I sure don't see a lot of older Oklahomans with flowers in their hair and tambourines. So I mean, I would hope that with that feeling that would somehow motivate you to stand up and challenge the ageisms, that no, just because I'm an older white male, I'm not the cause of the problems. And I think society also has got this view right now of the boomers, but we have to be realistic too, that many of the laws and situations that were created by people who are now boomers. Many of the laws and situations that were created by older white males because of the fact that who is elected and who makes the laws, older white males. So as to any kind of stereotype or false depiction, there's always that kernel of truth. But what we need to do is to fight hard for that 3/4 that isn't true. So I know that doesn't address the question at all, but
Thank you for addressing it. Actually, you did address it and name what's going on. Question from Sherry. I understand that it is not rude or intrusive to talk to mom, dad, etc., but there is a respect issue. How do I start the conversation without appearing disrespectful?
well, the same way you would just talking about anybody else. I mean, you know, we've got this we kind of always step back that we've got to use kid gloves for mom and dad or anybody that's got a wrinkle. We got to be careful, but I think the best way to approach it is, I care about you. I'm concerned about you. You don't seem like you're yourself. You don't seem like you don't seem like you're feeling good. I care about you. How can I help? What can I do? Will you please talk to me about it? Tell me more. And that's a real important statement. Tell me more. And it's not, a lot of times it's not so much as saying what is the matter, but trying to find out what matters. You know,
I think
what's bothering you, not what's wrong with you.
the next question may relate to this, from Lance. How do we quantify the difference between someone with recurring pain and someone in chronic pain that may be considered a candidate for assisted suicide? Well, that's a heavy one.
Yeah, I'm not going to, I'm sorry, but I'm not going to address anything with assisted suicide. I can't, I'm not going to go there because I'm not qualified to go there. But in terms of how do we quantify, I would think we would have to have medical professionals would have to deal with that. I'm not sure I'm not sure a mental health professional could deal with that. So I would assume that a medical professional would have to be measuring someone's pain and the ability to alleviate some of that pain. But then we all know that all of our bodies are different. We all age differently. So, you know, Mr. Jones over there, X amount of opioids may do it for him, where, you know, Mr. Smith that lives right across the street may need much less to alleviate his pain. But, you know, we don't know. We can't really diagnose. We can't really tell a person's pain because it is very individual.
Thank you. Stacy asks, would you consider giving up, no longer wanting to get up out of bed or do anything and let health fail, a form of suicide? So giving up. Interesting.
Yeah, definitely. So the problems with statistics, as you know, they say you can prove anything if you skewer statistics enough, but many times it depends on who's collecting the data. So we do believe that the rates of suicide for older adults are probably much higher than are reported because of the fact that there are situations where people just, you know, give up. They don't want to eat anymore. They just let their health deteriorate. That is a form of suicide, but yet it's not going to be reported. It's going to be reported as a natural death. So that is an issue. But yeah, if someone is no longer wanting to get out of bed, they definitely need some help.
Giving up at that point. Well, Karen, we could talk to you for hours. I have a hunch that there are many more questions. I will say that we are at the top of our webinar hour, and I know all of you all thank me and join me in saying thank you to Karen Orsi. What an amazing presentation. Those that have their cameras on are clapping and saying thank you. And there are others. There was a question here as well about the presentation being available. The video will be available at crisiscareministries.net. We're going to stay on just a few minutes after we turn the recording off, but let me say before you go, we hope to see you next week as we welcome Carly Ray Van Zant. She's going to be talking with us about crisis communications, what to say, how to say it. You're going to have some templates for fill in the blank, how you can communicate when there's been a crisis within your community. So again, Karen, thank you so much for being here. I saw your presentation at a state at a state conference and knew right away that I wanted to get to know you and bring you to these amazing faith leaders and community leaders that we have here. So thank you all for being here. We'll stop the recording now and stay on for a few more minutes of conversation if you'd like. Lots of thank yous in the chat.
Thank you.